Hi guys, we're going to focus in on medication administration and safety. And we're going to start with safety first and just get started here. So when we think about medication administration, we need to know our role and what everyone else's role is in this process. So the prescriber, that's the physician assistant, or maybe the nurse practitioner. They all have prescriber abilities, and their role is to obtain the history, to diagnose, to prescribe, to monitor, and to modify any therapy. When we think about the pharmacist role, the prescriber puts the medication in the computer and the pharmacist reviews the order. Then they compare it to other medications being taken just to double check there aren't any interactions, and then they can prepare and distribute the medication. Distribution of medication could include bringing it to the floor, loading it into a med dispensing station, whatever that looks like in your own specific facility. And then we can look at the nurse's role. This is our role. This is when we come into play in this scenario. So after it's been ordered by the physician, the pharmacist has checked it, we get the order, we have to understand the medication. So we are the last point before it gets to the patient. Those 3 checks. We can't rely on the prescriber or the pharmacist. If something goes wrong, yes, the physician is liable because they wrote the order. Yes, the pharmacist is liable for dispensing the medication. But guess what? We are also liable for giving the medication. So we are expected to know these medications, understand how to prepare, administer it, and then how to evaluate it. We need to develop and maintain our own knowledge of medications. We need to determine the accuracy of the medication and safeguard the medication and storing it appropriately to prevent any errors. So what do we need to know to give a medication? We need to understand the medication itself. There are over 11,000 medications. Are we going to know everything about each of these? Absolutely not. No way, not possible. But the expectation is that we will look it up. You may work on a floor that gives aspirin to every patient every day, and you will know that medication and not need to look it up each time. But one day you may be asked to give a different medication and have no idea what it is. You will be expected to look it up. So we can see pharmacology involves the medication category, mechanism of action, what are the therapeutic effects, what are the side effects, knowing that some side effects can be good. Things that happen we expect to happen, but we need to monitor them. And we'll talk a little bit about that here in a minute. Toxic effects are when the blood levels become too high, and it could cause permanent damage to the body. Ototoxicity with vancomycin is permanent damage to hearing. We can look at interactions. Most patients are on several medications, and do they interact with each other? Precautions or contraindications, and then how's it going to interact with my patient? Pharmacokinetics has 4 phases, and this should be review for you. We can talk about absorption. Absorption will determine effectiveness. Distribution is the transportation of the medication. Metabolism, and then excretion, which is eliminating that medication out of the body. With medications, we know that the drug has multiple names. Again, this should be review from pharmacology. You should be really familiar with both names for the drugs you're working with. Oftentimes, one of the names is very common because you hear it frequently. Lasix, we hear that all the time, but we need to know that furosemide is the other name for it. So making sure we know both names. Chemical name is not one we usually know. That's usually the composition of the medication. It's the generic and trade or brand name that we should be familiar with. So parts of the medication order, these are other things that you have to know if you're going to give medication. When a medication is prescribed, this is what is given to us. The provider puts it in the computer. They can handwrite it or maybe even give it to us over the phone. These are things they should provide for us. The patient name, the date and time that the order is written, what is the name of the drug that we're going to be administering, the dosage, the route by which the drug is going to be given, the frequency of administration, and then the signature of the person writing the order. So you can see here is an example of a common prescription. It's got lots and lots of pieces to it. This might be actually what you see in the hospital system. There are several different systems. Epic, Cerner are a couple just to name a few, but this is your MAR, or your medication administration record, and this is what will give you your rights that we'll talk about shortly for your medication administration. So again, also different supply systems, different types of orders. Orders can be given as standing or routine. Those are the most common. The doctor starts it, it keeps going until someone tells them to stop it. So Lasix 20 milligrams daily, they'll probably take that for the rest of their lives. A single or one-time dosing is just what it is. Vaccination is a common single or one-time dosing. You give a flu shot one time a year. Stat versus now. Stat meaning urgent, stop all priorities and do it now. Now means I'll do it next. You usually have about an hour and a half or 90-minute time frame to get it done. That's going to really be based off your hospital policy. PRN is based on as needed, so based on the patient's symptoms. PRN for pain, itching, fever. If the patient says I'm in pain but Tylenol is written for fever, you can't give it. So PRN always tells us what we are giving it for on an as needed basis. Standing orders are those orders that generate with diagnoses. So pneumonia may have a standing order for an antibiotic, or maybe magnesium will be ordered for an electrolyte imbalance to give it if the level drops below 1.5. Those would be your standing orders. This terminology goes into different adverse effects of medications. So when we talk about side effects, these are the unexpected problems that could occur secondarily or unintended to the medication. Allergic effects are an immune response. Toxic effects, too much medication has created a high level in the bloodstream that can cause damage or even death. Tolerance is building higher levels that the body no longer can react to. So you take a certain medication, it doesn't work anymore, so you have to take more medication. You've built a tolerance to that. Always ask about allergies and put that information in the chart. Before each time we give a medication, we should be asking, do you have any allergies? Every time. Because guess what? The one time the patient may say, oh, I forgot, I'm also allergic to fill in the blank, right? Maybe you've asked it 30 times during the day. And then you ask it one more time and then they give you that information. So ask every time about allergies. So what are some common signs and symptoms of drug allergies? We can think about rash, urticaria, which are hives, fever, diarrhea, nausea, vomiting, and then we can have anaphylactic reaction where two systems are involved in that allergy. So now we need to measure our medications. Looking at dosage calc so we can prepare for this. Most people understand the household method better than the metric system. We still use the metric system in the hospital because it's much more accurate. But when we discharge a patient to home, we need to convert those measurements into terms they understand as household measurements. Most people have a teaspoon at home, but not ml measurements at home. some people may not even know how many milliliters are in a teaspoon. So we need to report these measurements in teaspoons, tablespoons, ounces, because that is what they know. You should know these conversions. If you don't, you need to know them. Making sure you are memorizing these. Always report in decimals and not fractures. So if we are giving 5 mLs, that we're going to write 5 mLs, not 5.0, right? We never have that trailing zero because someone could quickly look at that and see 50, and that could be deadly. So no trailing zero. We do always use a leading zero. So half of a mil would be written as 0.5. If we didn't use that zero, someone may not see the point and give 5. So always write 0.5. We'll always write in decimals, never in fractures, and we always lead a zero, but never trail with a zero. So make sure we are following all the rules to give safe medication. When we give medications, we always do things in threes. We know our rights for medications, and we will make sure we go through those 3 times before administration. So we'll go to the Pyxis or the medication station. We'll do a medication check, all the rights. After I have my medication, I will go to the computer, and that's the second medication check, all of the rights. Then I will go to the bedside and verify all of the rights again with the patient. This helps the patient know what they are taking. Medication errors are huge. 400,000 errors every year, with 100,000 of those being medications. These are reportable events, so you must tattle on yourself. We need to know why it happened and how to prevent it in the future. So you can see on that pie chart, 78% of the time errors happen, it's because the nurse is rushed, right? That seems terrible. We rush around, and then we make errors. 68% is just poor handwriting. So making sure we clarify that before we give. So many different reasons due to reporting. So occasionally you may be able to report these errors anonymously, but most of the time you have to own that error. You just need to know you have to report them. We don't want it to happen again to other patients. Safety is always the top priority, and protecting our patients is the most important. Watching for any adverse outcomes of the patient. If the patient gets a med error, we have to do an assessment. If the patient has an adverse reaction, we need to document all of that. These errors are documented inside the patient chart with the facts, and outside the patient chart with all of the problems that led to the error. So this is just another slide, 9 types of nursing documentation errors. You can see sloppy or illegible handwriting, incomplete or missing documentation, using wrong abbreviations. Just again, different ways errors can happen. Other medication errors can come with look-alike and sound-alike medications. So you can see in the green box there, gabapentin and gemfibrozil, they look alike, right? But a gabapentin is an anticonvulsant. The other one is a cholesterol med. So imagine getting those wrong, right? If we have a patient with seizures and we give the cholesterol med, it's not going to help them with their seizures. The ones on the right, the hydroxyzine and hydralazine. Hydroxyzine is an antihistamine. Hydralazine is a blood pressure medication. So again, imagine giving the wrong medication, right? If our patient is having an allergic reaction and we give a blood pressure medication, it's not going to help their allergic reaction. We also have errors that can occur based off abbreviations that might be error prone. And we've talked a little bit about these in Concepts 1 and Lab that one day. HS, big H, big S versus little h, little s, bedtime versus half strength. OD or O period D period, once a day, right eye. So just thinking about those different abbreviations that can also cause medication errors. So what can we do to prevent some of these errors? We can use tall man lettering for look-alike drugs. So you can see all capital, lowercase, and then tall man. So let's take, for instance, the hydroxyzine, hydralazine, right? You can see it all in big letters, look alike. You can see it all in lowercase letters, they look alike. But when we put the tall man letters in there, you can see the difference. The OXY gets your attention, right? Or the ALA gets your attention because we throw those tall man letters in the middle. So using simple tall man lettering for look-alike drugs helps prevent these medication errors. Okay, let's talk about the 6 rights. The 6 rights of medication are an accurate way to prepare and administer medication doses. So, do we have the right medication, right patient, right dose, right route, right time, right documentation? When we think about the right patient, we need 2 patient identifiers. We can use the computer to compare the bracelet and ask the name and date of birth. When we think about the right medication, does the medication label match the MAR? So making sure we're pulling the correct medication. So we have the medication, we look up all of our medications, not just that you have the name of the med, but is it the right medication for your patient? And their diagnosis, their lab values, what are any adverse reactions that we may need to be aware of. So right medication, the right dose. This is where your calculations come into play. We're gonna check our math. We're gonna compare it to the pharmacist's math. And is it a therapeutic dose for my patient to be effective? We do need to remember that meds with enteric coating are gonna taste awful if it's chewed. So we never wanna chew or break any medications that have an enteric coating. The right route. So can this medication be given by the route ordered? And if it's an injection, making sure that we are preparing it for the correct use. Is it the right time? Is it the right time for our meds? Usually we have a 30-minute window on either side of the time. Again, this may be facility to facility. Remembering priorities would come into play if you have several medications due at the same time. Is the medication PRN scheduled or a one-time only? So if we have morphine, PRN, Q2 for pain, we need to look at the minimum that we have to wait before we can give it again. The last one is documentation, the right documentation. We want to make sure we document after giving our meds. Pull up the MAR, scan the patient, scan the med, give the med, make sure it's swallowed, and then click that it was given. And that is the correct documentation. So your medical record documentation should have the name of the med, what was the dose that we gave, what route and time that we gave, the nurse's initial, were there any intentional or inadvertent omitted drugs, did they refuse any of their meds, and were there any medication errors? We do need to make sure we are maintaining our patient's rights. So they need to be informed about the medication. Do not hand your patient a cup full of medications without informing them of what they are taking. Take the medication in the original packaging, show them, tell them what they're taking, and educate them why they are taking the medication. If the patient understands what they are taking and why they are taking it, they will be more compliant about taking the meds at home. If they refuse a medication, they have that right. Always true for those cognitively intact. They can say no. We should ask why they are saying no. Maybe they just don't understand, and maybe they need more education. They have the right to have a medication history. So ask them about all the medications they're taking at home and what they're taking in the hospital. We can medication reconciliate all of those. When they're admitted, write down all of the medications and then verify the orders. We need to make sure there isn't any drug-to-drug interactions. They have the right to be properly advised about experimental nature of medications. They have the right to receive labeled medications safely. So right to see the label. So again, don't bring in a cup full of pills. Make sure it's in that original label. Verify that they're getting the right medication. All meds are individually packaged, so they should be able to see that label. They also have the right to not receive any unnecessary medication. If your patient tells you that they've been taking amoxicillin, which is an antibiotic, every day for the last 5 years, that's not necessary. Talk with the provider and advocate for that patient. They also have the right to be informed if medications are part of a research study. So let's work through our nursing process when we're thinking about our medication administration. The nursing process gets us through every aspect of nursing. So what's the first step? It's assessment. What do we need to assess before administration? We need to ask about allergies, whether that be to food, medications, dyes. We need to ask what medications they're on. Are they prescription, over-the-counter, street drugs? What is their diet? Do they have diabetes diet? Are they on a low-fiber diet? Asking about different diet history. What is their level of education? That's going to help you understand, do they understand their disease process? Do they understand the medication therapy that they're going to have to go through? What is their social support, financial support, attitude about medication? Do they understand why they are taking the medications they are taking? Try to remove the obstacles. If they complain of getting up all night to pee and they take Lasix, then maybe we need to encourage them to take it in the morning. Teach them about their medication and the importance. So the next step is analyze. Don't really have to do a lot of analyzing unless it comes to a time crunch. So then the next step is planning. So making sure you organize yourself. Don't be rushed. Remember, 87% of errors occur because the nurses were rushed. Make sure you go through your 6 rights and your 3 checks. Take the label into the room with you so you can educate the patient. Accuracy is key. So now we're in the intervention or implementation, right? Avoid distractions. Administer only what you draw up and then document afterwards. 6 checks, 3 times. After we give the medication, evaluate. Did it work? All right, let's move into medication administration. So when we think about medication administration, we can think about administering them orally, by mouth, topically, meaning skin, nasal, eye, ear, vaginal, rectal, inhalation, irrigation, parenteral, and injection. And we'll hit on each of these here. So administering oral medications, this is the easiest and most commonly used route. It's the most convenient and comfortable and least expensive. Tablets, capsules, liquids, suspensions, elixirs, lozenges, right? All of those are our oral medications. There is a little bit of a barrier for absorption because the medication has to pass through the layer of the epithelial cells that line that GI tract. So it's a little bit slower onset, so more prolonged. It typically also is less potent. And we do have to be mindful of any aspiration precautions that our patient may have if they are administering meds orally. So oral route is having that patient swallow the drug, right? It goes in their mouth and they swallow it. Enteral route can also be a form of oral, but we're administering that drug through an enteral tube, right? We talked about NG tubes, NJ tubes, G tubes, right? It's going to their belly. It's just going in an enteral route. Sublingual is placing it right underneath the tongue, and buccal is placing that between the tongue and the cheek. All different ways of administering oral medications. Enteral or small bore feedings. If the medication is to be given on an empty stomach, just allow it at least 30 minutes before or after the feeding. So if they're being fed through their enteral feeding, we need to give it on an empty stomach, stop the feed, wait 30 minutes, and then give it. So again, here is your tablet, sublingual underneath that tongue, buccal is in that cheek. All right, and then there's different ways, crushing and cutting. Remember, you should always check with the pharmacist before you crush or cut any medications. Some medications are not meant to be crushed or cut. The enteric coating ones for sure cannot be crushed or cut. So just making sure you're checking with your pharmacy. For the most part, you're going to see the pill splitters. That's that picture on the left. We'll work with the crushing mechanism in lab this week. That's that one in the middle. Clearly those other ones are just kind of old-timey, but again, who knows? You may still see some of those somewhere. So as nurses, when we think about controlled substances, remember these are our narcotics. So if we are disposing of narcotics, we have to dispose of that in front of someone. You always have to have a witness. So let's say your prescriber orders oxycodone, 3 mLs, and your drug comes in a 5 ml package. So we need to dispose of 2 mLs. You have to dispose of 2 mLs in front of someone. You have to have a witness for a waste. So as we move to talk about topical administration of medications, topical is applied to the skin or in some type of a body cavity. Remembering we're using standard precautions with these, right? We need to have gloves on. So apply with a gloved hand. You can use a tongue blade or cotton tip applicator if it's going into some type of body cavity. Surgical asepsis if we're applying it into a wound. So when we're talking about topical and the skin specifically, we're using our gloves. If it's an open wound, again, we're using a sterile technique. We're going to clean that skin really well first using soap and water before we apply the medication, and then making sure we're just following the direction for each type of medication. Transdermal patch is the next topical one we'll talk about, and this is just really applying a disc or a patch that contains medication to the skin. So it's going to give a systemic effect in the form of a patch. So hormones, narcotic analgesics, cardiac meds, nicotine, right? Those all come as patches. It usually is associated with most adverse drug effects. The patch should be marked with the date and the time it's applied, and then make sure we're removing that old patch before we apply a new one. I also would highly recommend wearing gloves, remembering that you're going to peel that off, which means medication is exposed. So if you are getting medication on your hands, right, that's just a systemic effect that you may have. When we think about nasal installation, standard precautions, right? We're wearing our gloves. We're going to lie our patient supine with the head positioned to allow medication to enter appropriately into that nasal passageway. We try to tell our patients to breathe through their mouth, stay supine, and not to blow their nose for about 5 minutes. So for sprays, we're going to prime that spray first, right? spray, 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 wait for you to see the medication actually come out. Then we're going to insert into the nose and spray away from the center of the nose while the patient inhales. So you can see that picture on the right-hand side. They're kind of going away from the center of the nose to apply those drops. When we think about eyes, again, another topical medication, we can think about drops or ointments. You can see the drops there is going to go right into that inside of the eye, or typically we only use it on the affected eye, but sometimes like things like with pink eye, right, a lot of times we'll encourage our parents or patients to at least use both eyes initially because it is so highly contagious. Remembering not to ever allow patients to share, excuse me, eye medications. When we talk about the ointments, you can see kind of that ribbon is what we call it. It goes on that inner eyelid, and that's how you apply that. As far as intraocular, it's usually like a contact lens looking disc. They're going to insert and remove that disc, and you'll just have to teach the patient how to do that. When we talk about our eardrops, again, we're still sticking with that topical. Remembering the structures are very sensitive to temperature. So we don't want cold drops, we don't want hot drops. We just need to have them room temperature. If there's any drainage from the ear, that typically will indicate an eardrum rupture. And a lot of times we won't do drops for those. So this slide just gives you the steps on ear medication administration. I will let you guys read that slide yourself. And then when we're thinking about medication administration in those ears, pulling the ear up with the patients greater than 3 and down in those that are under 3. So that just straightens out the canal. So if you grab the kind of the middle of their ear, if you go up, they're greater than 3. If you go down, they are less than 3. And again, it's just straightening that canal so those drops can get where they need to go. Vaginal installation there, it just literally just goes into that vaginal opening. You can push that in with a finger. You can push that in with a like dropper thing. Put the knees bent, feet flat on the bed. Make sure you're providing perineal care if needed. And then they should lie supine for about 5 minutes just to help with absorption. For rectal suppositories, we want to make sure we position our patient on the left lateral side, or our Sims position. Usually used for laxatives, fecal softeners. If our patient is NPO and they need meds, we may need to give medications this way. Systemic effects can be achieved, although they are sometimes very erratic. So you can see on that right side, that right picture, right there on their left lateral, you can see the anal rectal ridge, the sphincter, and the suppository. So you're just going to place that right into that bottom hole, and you're just going to hold it in there till you start feeling like it is absorbing, like it is melting, and then just have them kind of clench that bottom together to hold it in. So when we think about inhaled medication as we move on, we can think about our meter-dosed inhalers, that picture on the left. The next to it is the spacer. You can also have little breathing treatments, so small volume nebulizers. And then that far right picture are dry powder inhalers, things that other types of inhalation processes that we can use for our inhalation medications. So when we're administering via inhalation, remember these are sprays, powders, mists. They're handheld, typically used for respiratory rescue or maintenance. You have your MDIs, your BAIs, your dry powders. They usually produce some type of a local effect, such as a bronchodilation. So a lot of times we're giving them because they are constricted. So we want a handheld inhaler. We use an aerosol spray or mist. It delivers a controlled dose of the medication. Medication is absorbed rapidly through lung tissue. In order for it to get to the lungs, everyone should really be using a spacer to help increase that medication so that it absorbs in the lungs and not in the back of the mouth. It has a local and systemic effects. Once they take that big deep breath in with their spacer, hold it for 5 to 10 seconds, and then exhale slowly with pursed lips. Make sure you educate them to rinse their mouth out after they are done with their medication, just to get rid of that residue that might be lingering. So patient teaching, review techniques of medication administration, remind the patient to take the med as prescribed for as long as it's prescribed. We do know like antibiotics are usually a 7 to 10 day period of time, but most patients are going to be better after 3 or 4. They still need to take all of their medication. Make sure they aren't going to alter their dosages without consulting a physician. Don't always tell them they shouldn't be sharing their medications with everybody. And then remind patients that over-the-counter meds can interfere with some of the prescriptions. So just be mindful about that. And then always document your teaching. A lot of times this is the last thing nurses forget to do, is document their teaching. If we teach a patient to do something, we should document that we told them to do that. And that concludes this lecture. If you have any questions, you can shoot me an email or we can chat about it in class. Thanks, guys.